research shows that most heart attacks occur at sites with less than 50% narrowing. The real question isn't how blocked are your arteries, it's how stable are your plaques. A small unstable plaque can be far more dangerous than a large stable one. Imagine carrying a ticking time bomb in your chest without knowing it. Coronary artery disease was previously considered a cholesterol storage disease. We currently view atherosclerosis as an inflammatory disorder. The bottom line, statins alone won't save you. Can exercise really help shrink plaque? The answer is yes. Low-fat diet was promoted for decades as the heart-healthy choice. But modern research is showing that it's far from the whole story. Olive oil, polyphenols. Think of this as your artery's natural shield. Intermittent fasting can lower the drivers of plaque growth and rupture. The bottom line, the sooner you start addressing these factors, the more likely you are to turn vulnerable plaques into stable, harmless ones. Peace be upon you and welcome back to Mend Human. I am Dr. Haitham Faraj, a certified cardiologist, nutritionist, and a personal trainer. And today we are uncovering the hidden truth behind plaque stability. What makes a plaque dangerous, how to prevent rupture, and whether it's even possible to heal or reverse plaques naturally. Most people think that heart attacks happen because arteries are almost completely or significantly blocked, but that's a myth. In fact, there are heart attacks which strike when the artery is only 40% narrowed. Why? Because the real danger isn't how much plaque you have, it's how unstable it is. Imagine carrying a ticking time bomb in your chest without knowing it. If you've ever been told your cholesterol is normal or your blockage isn't severe enough, this video could be life-saving. Stick with me till the end because I'll also share what tests truly matter, which therapies work, and the powerful natural interventions that science is finally recognizing. Let's break the silence around what really causes heart attacks and strokes and how you can take back control. Now let's begin by understanding what plaques actually are. Atherosclerotic plaques are not just cholesterol deposits. They are complex structures made up of cholesterol, immune cells, fibrous tissue, and often calcium, especially as the plaque matures, embedded within the artery wall. But here is the crucial part. Not all plaques are created equal. There are two main types, stable plaques and unstable or vulnerable plaques. For stable plaques, these have a thick fibrous cap, a smaller lipid core, and minimal inflammation. They're like a well-healed scar, present but unlikely to cause any trouble. However, the unstable or vulnerable plaques, these have a thin fibrous cap, a large soft lipid core, and are surrounded by active inflammation, making them fragile and dangerous. Think of an unstable plaque like an inflamed skin pimple. It may not look that big, but underneath it's swollen, irritated, and filled with inflammatory material. That thin outer layer, the fibrous cap, is like the fragile skin covering the pimple. If pressure builds or the surface weakens, it ruptures. And when that happens inside an artery, the body rushes to seal the rupture with a clot, which can block blood flow entirely, triggering a heart attack or sudden death. This is why degree of blockage isn't everything. In fact, research shows that most heart attacks occur at sites with less than 50% narrowing. According to a peer-reviewed study by Dr. Peter Libby, a professor of cardiovascular medicine in Harvard School, highlighted in the Journal of Circulation in 2005, he said coronary artery disease was previously considered a cholesterol storage disease. We currently view atherosclerosis as an inflammatory disorder. Think about this. This information was already being discussed back in 2005. Yet here we are in 2025 and the dominant narrative still insists that LDL is the main culprit and must be driven down at all costs. But the truth, which perfectly aligns with the mission of this channel, is clear. The real drivers of cardiovascular disease are insulin resistance and chronic inflammation, not cholesterol. Dr. Peter Libby highlighted also in this study, he said, we now recognize that disruption of plaques that may not produce critical stenosis causes many acute coronary syndromes, which is exactly what we mentioned in this video intro. You can have a non-critical stenosis or non-significant stenosis like 40 or 50%, and if it ruptures, it can still lead to an acute coronary syndrome. In this same study, Dr. Peter Levy said that recent results have established the multiplicity of high-risk plaques and the widespread nature of inflammation in patients prone to develop ACS. This perfectly underscores that heart disease isn't just about one bad plaque. It's often a whole network of vulnerable inflamed plaques waiting to rupture. Well, no wonder cardiovascular events are the leading cause of death globally. Many people who suffered sudden cardiac death were previously told they had non-severe blockages. That's because a small unstable plaque can be far more dangerous than a large stable one. So the real question isn't how blocked are your arteries, it's how stable are your plaques. Hey, sorry to pause here, but I just want to say thank you for watching up to this point. If you're finding value in this content and you're serious about improving your metabolic health and mending your body, please consider subscribing to the channel. It truly helps support what we're doing here at MenThuman and allows us to keep bringing you evidence-based, life-changing health information. Thanks again, and now let's get right back into the video. So, how plaques are detected and assessed. Now that we understand that plaque stability matters more than size, the next question is, how can we detect dangerous plaques before they rupture? Fortunately, modern imaging gives us powerful tools, not just to see blockages, but to understand what kind of plaque we're dealing with. The number one imaging tool that we have is the coronary artery calcium score, CAC. This is a non-invasive CT scan that detects calcium buildup in the coronary arteries. A CAC score of 0 is reassuring, but not foolproof. It means no calcified plaques are present, but soft, non-calcified, and potentially unstable plaques could still be lurking under the radar. It's best used as a risk assessment tool, especially in asymptomatic individuals. So briefly, what the numbers of the CAC score means: if you have a score of 0, that means you're low risk, but still not immune to soft plaque risk. If your calcium score is 1 to 99, that means you have mild calcification, generally low to moderate risk, but follow-up and lifestyle optimization are important. If your score is 100 to 399, that's considered moderate calcification, which is significantly higher risk, warrants aggressive risk factor management. If your score is greater than or equal to 400, that means you're having high calcification with a very high risk of coronary event, and that's a strong consideration for intensive medical and lifestyle interventions. The bottom line, a low CAC score doesn't guarantee you're in the clear. Soft plaques don't show up here, and higher scores demand progressively more urgent attention. The second imaging tool that we have is coronary CT angiography. Unlike the calcium score, coronary CT angiography gives a detailed image of the artery walls and the plaque itself. It can show whether the plaque is soft or calcified and identify dangerous signs like positive remodeling, in other words, artery wall bulging, low attenuation, which is a sign of soft, fatty core of the plaque, spotty calcification, and napkin ring sign. This is a high-risk pattern of thin cap fibroadenoma. In this short video, it will be difficult and overwhelming to cover all 4 signs of dangerous plaques in detail. So for now, let's focus on just one, which is the most common to be seen: positive remodeling. Okay, this image is adapted from Motoyama et al. It's a CT coronary angiography and shows a positive remodeled plaque in the left anterior descending artery. The yellow outline marks the vessel wall, and the purple outline marks the blood channel of the lumen. At the plaque site illustrated with the letter P, the vessel wall has expanded outward compared to the nearby healthy reference segment labeled as the letter R, but the lumen is still noticeably narrower, meaning the plaque is large enough to reduce blood flow despite the artery's attempt to compensate. This lesion over here is significant and requires an urgent intervention. Now let's look at another example, this time of positive remodeling where the narrowing is only about 40%. In this 3D reconstruction on the left, we can see the right coronary artery mapped clearly. The right panel with the yellow arrows highlight a segment that appears only mildly narrowed. If we performed a regular coronary angiography on this patient, the report would likely say non-significant stenosis, no intervention needed. And that's exactly the danger here. Coronary angiography only shows the lumen, the hollow channel where the blood flows. It doesn't show the full thickness of the artery wall. But in this CT angiography, we can clearly see what's hiding beneath that 40% narrowing: a large, deep plaque buried inside the vessel wall. The hallmark of positive remodeling. The artery has expanded outward to accommodate the plaque, keeping the lumen relatively open. This is critical to understand. Even though the narrowing is not significant by angiography standards, the plaque is large, lipid-rich, and inflamed, features that make vulnerable to rupture. If this plaque ruptures, it can suddenly block the artery completely, triggering an acute coronary syndrome. So a 40% lesion here is not benign. It's a high-risk plaque that needs aggressive medical therapy, lifestyle intervention, and close follow-up. A landmark study by Motoyama et al., published in the Journal of American College of Cardiology in 2009, followed patients with suspected coronary artery disease and found that high-risk plaque features detected by CT coronary angiography, such as positive remodeling, were strong predictors of future coronary events. The second imaging tool is intravascular imaging, IVUS and OCT. These are invasive tests typically done during cardiac catheterization, but they give unmatched detail. Intravascular ultrasound, or IVUS, provides a cross-sectional view of the artery and plaque burden. Optical coherence tomography, or OCT, gives microscopic resolution, allowing visualization of fibrous cap thickness, lipid core size, and signs of plaque rupture or erosion. These tools are considered gold standards for understanding plaque composition and guiding interventional decisions. So, to all interventionists, the next time you see a 40-50% non-significant lesion, don't just close up and conclude the story with
medical treatment only.
If you have the tools, use them to assess the plaque's true nature. You might be preventing your patient from a life-threatening event. You will be guiding them to take their health more seriously, knowing they carry a ticking time bomb that could trigger a life-threatening event at any moment. Now, let's say we find a vulnerable plaque during an advanced imaging test like IVUS or OCT. Should we go ahead and do PCI or put in a stent? The short answer is not usually. If that plaque is causing less than 50% narrowing, for example a 40% stenosis, and the patient is stable, guidelines don't recommend stenting. That's because these narrow plaques usually don't limit blood flow, and stenting them hasn't been proven to prevent future heart attacks in stable patients. Instead, the gold standard is aggressive medical therapy, high-intensity statins with other cholesterol-lowering medications like PCSK9 inhibitors, antiplatelets when indicated, strict blood pressure and sugar control, quitting smoking, and most importantly, improving lifestyle habits. Why? Because vulnerable plaques can be stabilized with the right treatment, making them far less likely to rupture. Stenting a non-flow limiting plaque can actually introduce new risks like blood clots or restenosis without clear benefit unless there's objective evidence of ischemia or the patient is in the middle of acute coronary syndrome. So the final takeaway for this section, it's no longer just about how blocked your arteries are. What truly matters is what kind of plaque do you have? Is it soft and vulnerable? Is it inflamed and at risk of rupture? And thanks to God and to modern imaging, we can now answer those questions more accurately and act before disaster strikes. Now, before we move on, we need to address an important question. Why calcified significant plaques often pose less risk? Dense calcified plaques often pose lower risk according to a major study in JAMA. A major study in JAMA Cardiology looked at whether the hardness of a plaque on a CT scan was linked to the chances of having a future heart attack. They measured hardness using a CT scale called Hounsfield units, HU. Plaques with a reading over 1000 HU were considered very dense, also called 1K plaques. The study found that people who went on to have a heart attack were less likely to have these very dense plaques, both when looking at the person overall and at individual plaques. In simple terms, the harder and denser the plaque, the less likely it was to break open and cause a heart attack. This calcification is often a sign that the plaque has healed and become more stable. In other words, a higher volume of dense calcified plaque is associated with lower risk of future rupture, making dense calcification a marker of stability. Now, switching gears, what about the choice between stenting or bypass versus medical therapy in patients with stable coronary artery disease? The ischemia trial, a study that many interventionists actually dislike because it challenges the necessity of some of their procedures, is still a landmark piece of research that simply cannot be ignored. The ischemia trial looked at over 5,000 patients with moderate to severe ischemia. They compared an initial invasive strategy, angiography and possible revascularization, versus a conservative strategy, medical therapy with angiography only if needed. Over a median follow-up of 3.2 years, there was no significant difference in death or ischemic cardiovascular events between the two groups. So even significant blockages don't automatically require intervention. If calcified and stable and not causing ischemia, medical therapy is often sufficient. Now, why this matters in understanding plaque stability. Dense calcification in plaques, especially high density, which is greater than 1000 HU, can signal a more stable, less dangerous lesion. Coronary angiography, while important, may not fully capture the risk profile. A lesion that looks severe on imaging might actually be stable and safe. Even a mild 40% narrowing might be high risk if inflamed and lipid-rich. Revascularization should target unstable ischemia-causing lesions, not simply those that look tight. The evidence shows invasive strategies don't automatically yield better outcomes in stable patients, even with significant stenosis. Now coming on to an important part. Can plaques be stabilized or healed? When it comes to atherosclerotic plaques, the ultimate question is, can we stop them from rupturing, and can they be healed or even reversed? The short answer is yes. Plaques can be stabilized and in some cases partially regressed. But complete cleaning of the arteries is rare. The real goal isn't to erase every plaque, it's to make them harmless by reducing inflammation, improving their structure, strengthening the fibrous cap, and lowering your lipid content, thus preventing its rupture. Think of it like turning a soft, fragile balloon into a solid, stable scar that's much harder to burst. Now, regarding medical interventions that are scientifically proven in plaque regression, number one, we're having statins. Statins are the most well-studied drugs for plaque stabilization. They don't just lower LDL cholesterol, but they also reduce inflammation inside plaques and thicken the protective fibrous cap, making rupture less likely. According to the Asteroid trial in 2006, they studied patients on high-dose rosuvastatin. Intravascular ultrasound IVUS showed measurable regression of plaque volume. But, a big but, if you're living an unhealthy lifestyle, eating poorly, and not exercising, statins alone can't save you. In my previous case presentation, I shared the story of a diabetic patient with poorly controlled blood sugar who wasn't following a healthy diet or exercising. Despite being on statins and having a low LDL, he still suffered a fatal cardiovascular event. The bottom line, statins alone won't save you. The second scientifically proven medical intervention that helps in plaque regression are PCSK9 inhibitors. They are extremely potent LDL-lowering injections, often used for high-risk patients who can't reach targets with statins alone. According to the Glagov trial in 2016, adding a PCSK9 inhibitor to statin therapy resulted in modest but measurable plaque regression. The third medical intervention that we're having is bempedoic acid. This is an oral LDL-lowering drug especially useful for statin-intolerant patients. To be fair, there is limited direct evidence that bempedoic acid causes plaque regression, but there is a compelling case study supporting it. According to a single notable case study, used serial CT coronary angiography to follow a statin-intolerant patient on bempedoic acid monotherapy. Over 20 months, the low attenuation soft plaque core shrank significantly, and the lesion appeared more stable. While intriguing, this is just one patient, so it's not enough to draw firm conclusions. However, according to clinical outcome evidence, the CLEAR Outcomes trial, published in the New England Journal of Medicine in 2023, showed that bempedoic acid significantly reduced LDL, lowered hsCRP, a good marker of inflammation which we covered in detail in our previous episode, and decreased the risk of major cardiovascular events in over 13,000 statin-intolerant patients. These benefits strongly suggest positive effects on plaque health and stability, even if large-scale imaging trials confirming plaque regression are still lacking. One of the most fascinating studies on plaque regression is the HEADS trial, standing for the HDL Atherosclerosis Treatment Study, published in the New England Journal of Medicine in 2001. In this trial, Patients with coronary artery disease and low HDL cholesterol were treated with a combination of simvastatin, a statin, and niacin, also known as nicotinic acid or vitamin B3. After just 3 years, imaging with coronary angiography showed something remarkable. Plaque volume actually decreased in the treatment group. LDL levels dropped by about 42%, while HDL rose by 26%. Most importantly, the treatment group had a 90% reduction in cardiovascular events compared to placebo. This trial demonstrated that with the right intervention, lowering LDL, raising HDL, and reducing inflammation, plaques don't just stabilize, they can actually shrink. So the key takeaway in this section: we may not always be able to make plaques disappear completely, but with the right therapies, we can transform these plaques from unstable, rupture-prone time bombs into stable calcified scars that are far less likely to cause a heart attack. Now we've reached the moment I know many of you have been waiting for. The big question that probably brought you here: can plaques be reversed naturally? When people ask if plaques can be reversed without medication, the answer is yes, to a certain degree. Lifestyle changes and certain natural compounds can shrink the soft core of plaque and, more importantly, make plaques more stable and less likely to rupture. The number one lifestyle intervention which is strongly proven to stabilize your plaques is the Mediterranean diet. The Mediterranean diet is a powerful tool for plaque stability. It is rich in extra virgin olive oil, nuts, fish, vegetables, and whole grains. Excluding modern wheat products is one of the most well-studied dietary patterns for heart health, and the science behind its effect on plaque stability is truly compelling. According to the CardioPref trial, the Mediterranean diet was helping in slowing atherosclerosis progression. The CardioPref trial compared a Mediterranean diet to the standard low-fat diet, which was promoted for decades as the heart-healthy choice. But modern research is showing that it's far from the whole story. So, this study compared a Mediterranean diet to the standard low-fat diet in patients with established coronary heart disease over 5 to 7 years. They found that the Mediterranean group had a significant reduction in carotid intima media thickness and decreased plaque height, while the low-fat diet group saw no significant changes. Another trial that examined the Mediterranean diet is called the PREDIMED trial, which have proven that it helps in reducing inflammation and vulnerability. In this study, high-risk patients were assigned to a Mediterranean diet supplemented with either extra virgin olive oil or nuts versus, again, a low-fat diet. After 1 year, inflammation markers linked to plaque rupture dropped dramatically. CRP decreased by 45% in the extra virgin olive oil and 95% with nuts. Interleukin-6 decreased by 35% with extra virgin olive oil and 90% with nuts. This shows the Mediterranean diet can directly reduce the inflammatory activity inside plaques. The bottom line on the Mediterranean diet: it doesn't just reduce heart attack risk, it can slow plaque progression, reduce inflammation inside the plaque, and shift its structure towards stability. This is a powerful, non-invasive prevention in action. So the key takeaway in this section: the Mediterranean diet is not just a healthy eating plan, it's a scientifically proven plaque stabilizer. When combined with weight management, regular physical activity, and targeted supplements, it becomes a powerful tool to prevent heart attacks without invasive procedures. The second powerful tool that we have in plaque stability is intermittent fasting. Now, how intermittent fasting helps. First of all, it improves insulin sensitivity and lowers blood pressure, even without weight loss. Secondly, it is scientifically proven that it reduces atherogenic lipids and blood pressure in metabolic syndrome with 10-hour time-restricted eating. It also dials down inflammation through ketone signaling, specifically beta-hydroxybutyrate. This is the primary ketone body produced during fasting. It inhibits the NLRP3 inflammasome, a key driver of vascular inflammation and plaque instability. Intermittent fasting benefits is summed up in a major New England Journal of Medicine review, which says that intermittent fasting improves multiple cardiometabolic markers relevant to atherosclerosis. This study is from the Hong Kong Polytechnic University. How big are the effects? So the main narrative reviews conclude intermittent fasting improves cardiometabolic risk profiles, supporting plaque stability indirectly. So coming to the main question, does intermittent fasting regress plaques? In humans, as of now, there are no robust human CT coronary angiography or IVUS trials showing plaque regression, specifically from intermittent fasting alone. If one exists, it hasn't been widely published or replicated. However, there are animal studies. Several studies in atherosclerosis-prone mice show less plaque burden and more stable plaque features under intermittent fasting regimens. These are encouraging but still not definitive for humans. So, the bottom line, intermittent fasting can lower the drivers of plaque growth and rupture by improving insulin resistance, blood pressure, atherogenic lipids, and inflammation, and may stabilize plaques indirectly. However, direct human proof of plaque regression with intermittent fasting is not yet available. Current support comes from mechanistic data, risk factor improvements, and animal models. Now coming to supplements with potential benefits on stabilizing your plaques. The number one powerful supplement is omega-3 fatty acids, specifically EPA or icosapentaenoic acid. High-dose EPA from purified fish oil can reduce inflammation and stabilize plaques. According to the Reduce It trial, they examined pure EPA in the form of a drug called Vascepa. Pure EPA reduced cardiovascular events by 25% in high-risk patients. The second important supplement is vitamin K2, specifically MK7. Vitamin K2 plays a crucial role in calcium regulation, activating proteins like matrix GLA protein MGP that prevent calcium from depositing in arteries, while directing it into bones where it belongs. This helps maintain arterial flexibility and reduces the progression of vascular calcification, key factor in plaque hardening. According to Gast et al., in a large population study of more than 16,000 women, the higher dietary intake of vitamin K2 was linked to significantly less arterial calcification and a lower risk of coronary artery disease. The third supplement that can help in plaque stability is olive oil polyphenols or oleucanthal. Think of this as your artery's natural shield. If you've ever tasted a peppery kick in your throat after ingesting extra virgin olive oil, that's oleucanthal. And it's not just for flavor. It's nature's gentle anti-inflammatory, a gift God has blessed us with. Oleucanthal, found in high-quality extra virgin olive oil, acts like natural ibuprofen, blocking inflammation, promoting enzymes, and calming key inflammatory pathways such as NF-kappa B. A study highlights which proves this. A comprehensive review describes oleucanthal's unique ibuprofen-like ability to inhibit COX enzyme and reduce inflammatory signals, calms inflammation in real bodies. In a randomized trial, the April study, extra virgin olive oil rich in oleucanthal and oleisin markedly improved oxidative and inflammatory markers in people with obesity and prediabetes, showing real-world anti-inflammatory action. Extra virgin olive oil polyphenols, including oleucanthal, strengthen the endothelium by reducing oxidative stress, boosting nitric oxide, which helps vessels relax and preventing inflammatory cells from sticking to the artery wall. It lowers the bad and strengthens the good. In human trials, extra virgin olive oil with high phenolic content reduced LDL oxidation and improved HDL function, making your cholesterol particles less harmful. So here are the key takeaways on why this compound matters for plaques. First of all, it helps in calming inflammation, helps strengthen the fibrous cap, reduce the chance of rupture. Secondly, it helps in protecting the endothelium, maintains artery flexibility, and prevents new plaque formation. Thirdly, it helps in forming healthier lipoproteins and slow plaque growth and make existing plaques less dangerous. The bottom line, supplementing with high phenolic extra virgin olive oil gives you oleucanthal's potent anti-inflammatory, artery protective, and cholesterol enhancing power, all in a simple daily habit. Can exercise really help shrink plaque? The answer is yes. And the most powerful form is high-intensity interval training or HIIT training. A groundbreaking randomized controlled trial published in the European Journal of Preventive Cardiology revealed that just 6 months of supervised high-intensity interval training performed twice a week at 85 to 95% of peak heart rate led to significant plaque regression in patients with coronary artery disease. Using advanced intravascular ultrasound IVUS imaging, researchers found that the percent atheroma volume PAV dropped by 1.2% in the hit group, while the control group saw no meaningful change. While 1 to 2% may sound small, studies show that even a 1% regression in plaque volume can translate into a meaningful reduction in cardiovascular events. And it's not just this trial. Other research confirms that exercise intensity matters. People engaging in vigorous aerobic training see greater slowing and even reversal of coronary plaque buildup compared to lower intensity programs. The bottom line, HIIT training doesn't just stop plaque from growing, it can actually shrink it and make your arteries healthier. Now coming to the bigger picture, plaque healing versus stabilizing, an important reality check. Completely removing plaque from arteries is extremely rare. Think of it as the exception, not the rule. But stabilizing plaques by reducing inflammation, thickening the fibrous cap, and promoting calcification can dramatically lower the risk of rupture and heart attacks. Healing isn't about making your arteries look brand new on a scan. It's about transforming dangerous, unstable plaques into more regressed, stable, harmless scars that no longer threaten to rupture. Along the way, improved blood flow and healthier endothelial function help protect your heart for the long term. So what's the key takeaway? The goal isn't to scrub your arteries clean, it's to disarm the ticking time bombs inside them. Now coming to an important part. What is your action plan? What you should do to stabilize your vulnerable plaques? First of all, you have to know your numbers. Test, don't guess. You have to request advanced blood work, ApoB levels, LDL particle number, triglyceride to HDL ratio, and hsCRP for inflammation. If you're over 40 or have multiple risk factors, get a coronary artery calcium score scan. It's one of the most powerful predictors of long-term heart risk. While it's not an absolute guarantee that soft non-calcified plaques aren't present, it provides valuable insight into your artery health and overall plaque burden. And of course, you have to eat, move, and live for artery health. Follow a Mediterranean or low-carb anti-inflammatory diet rich in vegetables, healthy fats like extra virgin olive oil, nuts, fatty fish or grass-fed meat, and avoid processed foods. Exercise regularly. Combine resistance training, moderate aerobic work or zone 2 cardio, and at least 2 supervised HIIT sessions per week. This powerful mix strengthens your heart, optimizes metabolic health, and can help stabilize or even shrink dangerous artery plaques. Then you have to prioritize recovery. Quality sleep and effective stress management are just as important as diet and exercise for reducing plaque instability. The third thing, you have to use medications or supplements wisely. Take an individualized approach, no one size fits all. For high-risk patients like diabetics or who had a previous cardiac event, this may include evidence-based medications like statins, PCSK9 inhibitors, or bempedoic acid, and targeted supplements such as omega-3s, vitamin K2, or high phenolic olive oil compounds shown to improve plaque stability. The bottom line, the sooner you start addressing these factors, the more likely you are to turn vulnerable plaques into stable, harmless ones and dramatically reduce your heart attack risk. Plaques don't have to be a ticking time bomb. You can diffuse them through lifestyle changes, informed decisions, and when necessary, targeted therapy. If you want to dive deeper into the science of cholesterol, heart disease, and how to truly protect your arteries, check out my book, Is LDL Really Our Enemy? Cracking the Cholesterol Code. It's packed with evidence-based insights and a 30-day plan to improve your metabolic and cardiovascular health. Available now on Amazon. In the next episode, we are going to address the real markers of heart disease you must know, from LDL particle size and ApoB to lipoprotein(a), hsCRP, triglyceride to HDL ratio, calcium scoring, and waist to hip ratio. You won't want to miss it. So make sure you're subscribed so you don't miss this important episode. Comment below if you've had a calcium score or share what your latest lipid profile looks like. Don't forget to like, share, and subscribe for more life-saving content. And remember, every comment, like, and share helps YouTube's algorithm push the video to more people who need it. So don't leave without engaging and share it with someone. It might just save a life. Visit mendhuman.com for virtual clinic consultations and personalized plans to reverse chronic disease. Note that the clinic launch is pending. Stay tuned for the official opening. That's it for today. Until next time, peace be upon you. Assalamu alaikum.